Good morning where I am, and good day wherever you are. Thank you, Dr. Delaney and Dr. Lambert, for these remarkable and insightful presentations. I want to focus the discussion on diagnostics and treatment choices based on the understanding of pathophysiology causing symptoms in our patients. So in order to identify best fit diagnosis and to choose the best treatment, we have to have a model. We have to have etiology and pathophysiology, and both of you spoke to that in your talks. So let's start with long COVID and Dr. Lambert. You note that most physicians believe that long COVID is a post-infectious autoimmune or immune dysregulatory process. But you also presented a very intriguing paper on the etiologies of RNA virus sequelae. I believe, favor dysfunctional brainstem vagus signaling. In the ICD-10 world, the dysautonomias as a likely cause of long COVID. And you also note you've seen low lymphocytes and immune dysregulation, which we'll talk about a little more later. And the paper mentioned enhanced clotting post-COVID as a possible etiology of some of what we see. Biome disruption was mentioned as a possibility, and persistence of COVID virus in some sites was also considered possible. Is it as well as organ damage, is it likely that several etiologies are occurring simultaneously? And can you just speak to how you think about that?
Okay, so when I see a patient with long COVID, I say the 5 components of long COVID are brain inflammation, immune dysregulation, mitochondrial crashing, microclot production with hypoperfusion of the tissues, and then finally, because you do get immune suppression and immune dysregulation, very often you get virus reactivation. You know, everybody has DNA viruses in their body, and there's lots of DNA viruses from EBV to CMV to HSV to VZV to HHV6 to HHVH. So all those are DNA viruses that can potentially reactivate in the setting of long COVID. So obviously, you know, long COVID is multifactorial. And I also tell my patients we've learned a lot from long COVID, the pathogenesis, to apply it to chronic Lyme disease, because Lyme disease is probably all of those plus a bacterial infection that will respond to antibiotics. But antibiotics alone in chronic Lyme doesn't do the job. You need to kind of deal with the other issues. And like I said, the other issues are immune dysregulation, brain inflammation, and I think probably, you know, mitochondrial crashing, dysautonomia, and probably viral reactivation are all parts of chronic Lyme disease. And I think we've learned that, or I've learned that from my dealing with long COVID patients.
Yeah, and Dr. Delaney, you similarly gave evidence that in some cases, we know there is persistent infection in both patient and animal studies. And you also showed PET scans, as did you, Dr. Lambert, the same study by Alcott, that shows glial activation as confirmatory of brain inflammation and cytokine elevations in Lyme disease. This, in some patients, may lead further to mast cell activation syndrome, which is something we're thinking about now in the area. You also mentioned neuroimmune, autoimmune antibodies and altered neurocircuitry. And I really wanted to ask you, I also want to mention, just highlight in your talk, that you had illness amplifiers, which was very helpful to me in my thinking about my patient. And you said PTSD, kind of invalidation of someone's illness by the medical community at times, living with pain, and the economic hardship and social isolation that can come from that, prior trauma, and the uncertainty of diagnostic testing. So I would ask you the same question. How do you think about these various etiologies when you approach a chronic psychiatric Lyme patient?
Yeah, I would say that I echo a lot of what Dr. Lambert said. I don't necessarily think of it as maybe multiple etiologies. It depends. I mean, if you have Lyme disease and also a co-infection like Babesia and Bartonella, then that might be multiple etiologies. But in general, I kind of think of it as one etiology with a complex pathophysiology. So there's like a lot of different mechanisms of actions that are going on. So similar to what Dr. Lambert thinks in terms of COVID, I think it's probably a combination of persistent infection, some sort of dysregulated immune response, potentially because of that ongoing infection, and brain inflammation in most of the patients that I see that present with neuropsychiatric symptoms. Mast cell activation is also an interesting concept. I certainly see potential evidence of that in a lot of my patients. I usually see some good responses with antihistamines. So that's another contributor, I think. We also see virus reactivation in the setting of chronic Lyme disease. All of a sudden, people's old EBV viruses are coming up. And in terms of psychological amplifiers, I think that there is a lot of medical, like, invalidation from the medical community, which is very unfortunate. I've thought a lot about how people with chronic Lyme disease diagnosis are actually in a very difficult position. And in some ways, their illness might not be life-threatening, but it's almost more difficult than a cancer diagnosis, for example, because with cancer, you go into your doctor, you see an oncologist, they tell you exactly what stage of cancer this is. There's understanding about the diagnosis, about the pathophysiology for the most part. There are clear guidelines for treatment. There's prognosis. Whereas like in our field, patients can't go home and like they're not told they have stage 3A Lyme disease. They can't go on the CDC website and learn all about it. There's so much uncertainty regarding the diagnosis and also the treatment. Also, from my perspective as a psychiatrist, I see a ton of neurological and psychiatric manifestations of these diseases. So super scary when you have a disease that's changing your personality in some way, whether you're an adult or a kid or a family trying to deal with that. It's not easy. And then also, I think that it's, in general, people with Lyme disease don't get the support that, for example, people with cancer get. So it's very rare that I hear that a family or friends are doing like a GoFundMe page for their Lyme disease diagnosis or bringing over dinners to support them. So it's, in fact, what I see all the time is that the families are in like complete crisis mode, and nobody is helping them, and it's just a very difficult situation. So yeah, I think that there are a lot of psychological amplifiers.
Right.
I also see frequently that the partner or the family is told by the physician that nothing is wrong with the patient. And this becomes dreadful. It, as you say, it takes away support. It's like the rug is pulled out from under them. I've had patients come in and say, Dr. Green, I'm so happy I have cancer. And what they mean is, good, they've been feeling this, and now they have something that they can approach and that they will be supported in approaching. Jack, did you want to say something?
Yeah, no, I was just saying is that, I mean, the whole term, post-treatment Lyme disease syndrome, I mean, I'm an infectious disease doctor, and I always stand by the fact that the only infection that seems to have a limited time period that you can treat people, even though they're still sick, is Lyme disease. Every other infection in the world that I treat I treat based on patient symptomatology. So, you know, I mean, it's the term PTLDS is, you know, has been really harmful, I think, for the patient community, is because PTL, post-treatment Lyme disease syndrome, does that mean post-infectious, or does it mean they're still sick after you've treated them? And my opinion is they're still sick after you've treated them. And if you did that with meningitis, if you did that with sepsis, if you did that with cellulitis, you go, oh, you know, treat them a little longer. But with Lyme disease, the infection's gone. And the proof that the infection's gone is there is no proof. And the proof that when you do a spinal tap in somebody and you say, oh, there's no antibodies in the CSF, therefore they don't have neurolyme. But we know that half the people who have Lyme disease don't have antibodies in their blood. Why would they have it in their CSF? And somebody come up with a ratio of, you know, if you have this ratio of antibody in the brain to the blood, then you've got Lyme neuroborreliosis. But if you don't have Lyme neuroborreliosis, but they have brain inflammation clinically. And finally, you know, 2 years into the infection's not in the spinal fluid, the infection's in the brain. So when you do a spinal tap, you're measuring some kind of infection in the meninges, but with Lyme disease, the infection's in the brain. You need a brain biopsy to prove that you have Lyme neuroborreliosis. But repeatedly, patients get told you don't have Lyme disease because you have a negative antibody test, you have a negative spinal tap, but the patients are sick and the patients have responded to antibiotics and they're denied further antibiotics because you've had your 2 weeks of doxycycline, that's the treatment in Ireland, and you don't even get a repeat treatment, you don't get IV treatment, and you're told that the infection is gone. And that, for a lot of patients, you know, triggers a lot of psychiatric manifestations. But actually, Lyme disease, the infection of the brain, triggers neuropsychiatric manifestations, and infection with COVID triggers neuropsychiatric manifestations. And, you know, we for some reason, we just seem to dismiss patients with these conditions because we don't have good diagnostic technology, you know. So this is really the challenge, I think, that for clinicians, but it's also the huge disappointments for what patients have to experience when dealing with the medical system. Your tests are all normal, therefore there's nothing wrong with you. Not true.
Yeah, and I'd like to put in here, you mentioned Legigian's paper, Dr. Delaney, and on neuroborreliosis, long time post the infection. And in their spinal taps, they did notice that increased protein was a marker of neuroborreliosis in some. There's a question from the audience that's pertinent here, I think, which is COVID-19 can lead to the formation of G protein antibodies, which can disturb the communication of important neurotransmitters. The result are problems with the autonomic nervous system, which again, both of you mentioned. Is this phenomenon also known for Lyme disease?
So Shannon, do you want to address that or say we don't know?
Yeah, either or. I mean, in terms of autonomic dysfunction, we certainly see a lot of that, or I see a lot of it in the setting of Lyme disease. A lot of patients that I see are presenting with POTS type symptoms, you know, postural orthostatic tachycardia syndrome, where they're coming in and they feel lightheaded or they're frequently dizzy or fatigued. And there's evidence of tachycardia upon standing. I think it's helpful when when patients present with those types of symptoms, I do send them to a cardiologist to do a tilt table examination, because I think it's helpful. Anytime you can get a more objective type diagnosis in this setting, I think it's usually a good thing. And then the recommended interventions, like increasing fluid intake and salt intake and compression stockings, can also be helpful for some of the symptoms. So yes, I do see a fair amount of autonomic dysfunction in this setting.
And actually, I would say that having taken care of Lyme patients for the last 10 years, and taking care of long COVID patients for the last 4 years now, is that I've learned a lot about probably the pathogenesis of what's happening with my chronic Lyme patients, because the studies have been done on long COVID, but the studies haven't been done on chronic Lyme. And there clearly is this dysautonomia. The studies that I presented on are, long COVID follow-up. About 20% of them have this unexplained anxiety. And, I saw a patient 2 weeks ago who's been sick for 3 years and, totally bedridden, POTS type symptoms, totally exhaustion, PEM, all that kind of stuff, just from long COVID. And I basically started discussing anxiety with her. And she just said, "I'm not anxious." She started shouting at me because she's been told so many times that she has an anxiety disorder. I wasn't trying to tell her she had an anxiety disorder. I was trying to explain to her that, yes, there is this autonomic dysregulation, sympathetic, parasympathetic imbalance. It's like I give the analogy, it's like the bunny rabbit waiting to be attacked by the fox. He's sitting there in adrenaline rush, waiting to be attacked, oversensitive, light sensitive, sound sensitive, tachycardia, probably blood pressure dysregulation, probably, thermoregulation dysregulation. This is an adrenaline rush that you get. And people who are previously calm people have this unexplained anxiety, and time and time, every week I see patients with long COVID say, "I'm worried about things that I didn't used to be before. I'm over anxious. I'm over nervous," and they're told they have an anxiety disorder. They don't. They have autonomic dysregulation. And then if you look at pathophysiology of, samples of vagus nerve samples of patients, from COVID, long COVID, the vagus nerve is damaged. And the vagus nerve, I think, can be contributing to the symptomatology of long COVID. And I suspect it's also contributing to chronic Lyme infection. So, we were asking the question, are these antibodies, that have been found in the brain, are they contributing to, chronic Lyme symptoms? Are they contributing to, long COVID? They probably are. But I think there's some kind of autonomic dysregulation from neuroinflammation, from damage from Lyme, from damage from co-infection, from damage from viruses that are triggering all these symptoms. So it's brain inflammation signaling downstream that's causing a lot of the symptoms we're seeing in patients with chronic Lyme, in patients with long COVID.
So they're similar. I also check for POTS, but I do it in the exam room. Peter Rowe presented at the Columbia conference this year that he no longer does tilt. And I do find my patients get very sick sometimes from a tilt test. So I have them lay down quietly on the table for about 5-10 minutes. And then we take 1 minute, every 1 minute blood pressures. We then stand them up and they lean against the wall with their shoulders just slightly. We attend them because occasionally they faint. And then I take every 2 minutes for 10 minutes. And I definitely do pick up postural orthostatic tachycardia syndrome, as well as orthostasis in other ways. So I want to just highlight pearls of diagnosis. So I believe, Dr. Delaney, that the pearls I can take for a diagnosis of a Lyme-caused psychiatric illness are atypical presentation of psychiatric illness, either by age or the presentation of it. Failure of multiple psychiatric medications to affect relief, especially if they're from different classes of medication. Cognitive features in the patients, new onset psychiatric symptoms with multi-systemic other symptoms appearing, especially if it's after a recognized illness, a viral illness or a recognized illness. Lyme endemic area, which may be the entire states at this point, and lab seroconversion. And you've just added to that kind of POTS as one of the things. Would you add anything else you see in the exam room or you hear in the history that maybe isn't as confirmed in the literature, but that your clinical sense leads you down that, oh, in this psychiatric patient, I better look for tick-borne disease?
Sure. So those factors that you mentioned, those pearls, I think that they're very stellar. They actually came from a paper that Dr. Brian Fallon wrote quite a while ago. But I find that they're very clinically applicable in terms of useful for physicians out there, psychiatrists, or even other doctors as well. The one caveat, I would say that most of those things that were identified, I think that that's a good approach and kind of algorithm to use for adults who have psychiatric problems and you might suspect Lyme disease. The caveat there is that I think, so I'm a child psychiatrist as well, so I see a lot of kids, often young kids, I see adolescents, I see all ages. And interestingly, in young kids, so these are like school age kids, I usually don't see the more typical, like more so medical fatigue, joint pain, things like that, symptoms related to Lyme disease. I frequently just see only psychiatric symptoms. And so the typical presentation for a younger kid would be actually like personality change, like erratic behavior, emotional dysregulation. All of a sudden the parents are saying like, this is not my kid. Like they were nice and calm and sweet, and now they're like out of control and they're being aggressive and they're having panic attacks. They might have new onset OCD or anorexia. So that is the one difference from that list. Those pearls, I think, are unique to adults. And with kids, I think no one really knows or understands that oftentimes in kids, they can present only with psychiatric symptoms, which is obviously very common.
And I guess my experience is I'm actually adult and pediatric infectious disease specialist as well. So I just officially see adults, but I'm seeing a lot of young adults, adolescents as well, and this whole concept of pandas, neuroinflammation, infections triggering inflammation that affect, so they end up with neuropsychiatric problems, behavioral problems, developmental regression. I mean, the brain, that's what happens with children when their brain's affected, So what I see, so many, 50% of the patients I see, whether it's with long COVID or long Lyme, they have neuropsychiatric problems. They have psychiatric problems as part of their problem. And many of them have been diagnosed as having anxiety disorders, depression, psychosis, all sorts of other things. And when I treat them with antibiotic, and similarly, they haven't responded to the standard psychiatric medicines that have been given them by GPs and other specialists. And when I put them on treatment, if it's Lyme disease, antibiotics plus supplements to support the immune system and support the inflammation, or if it's long COVID, where I don't give them antibiotics, but I do things to support neuroinflammation, LDN, other supplements, etc. My experience is very often their anxiety goes away, their psychiatric problems go away, their depression goes away, their mood gets better, sometimes their psychosis goes away. And I keep on, and with Lyme, I say, I didn't give you an antipsychotic, I gave you an antibiotic. Antibiotics worked against bacteria. So there must be a bacteria up there in the brain triggering this. So, I just think that it's unfortunate that we put people in the psychiatric basket so often when we can't explain their symptoms. And this makes the physician feel good. You have pain all over. Let's call it fibromyalgia. You've got neurological symptoms we can't figure out. Let's call it functional neurological disorder. You're tired all the time. Let's call it chronic fatigue syndrome. You've got neuroinflammation. let's give you a psychiatric disorder. I mean, I'm an infectious disease doctor. Infections trigger many conditions, and just because you don't have the technology to diagnose it, I think it's really unfair to the patients to put them in these categories that just actually give them a label and deny them an opportunity for further treatment.
So I am curious with both of you. Oh, Dr.
No,
Delaney.
I was just like wholeheartedly agreeing with what he said.
Yes. In your practice, I'm curious for both of you, what is the longest time between onset of symptoms in a patient and diagnosis of either Lyme disease or long COVID that you have seen in your practice? I think that clinical marker might be helpful for those who are beginning to approach these chronic diseases, chronic infectious diseases.
Well, I guess I can speak from my perspective. I think it's something it's very hard to kind of grapple with as a physician sometimes in this realm, especially as a psychiatrist, because I frequently will encounter patients, for example, who are teenagers who present with new onset psychiatric symptoms kind of out of the blue. Sometimes it's because there was some other like stimulating or triggering event, like getting a vaccine, for example. And then all of a sudden they have panic attacks and new onset OCD, and they're 16 years old. And when they were 8, they had a history of Lyme disease. So it's like,
yeah,
it becomes very complicated. So is this now active Lyme disease? This is one of the huge like examples of where it would be great if we had a test that would actually be a great test for active infection, because I think this would clear up a lot of the confusion and the uncertainty in this realm. So this is that kind of thing I see a lot. And it's very difficult to kind of untangle, to be honest. I do the same kind of workup as I would do with a new patient who didn't have that history of Lyme disease, and I kind of see what we find. If a patient presents, for example, with an elevated ELISA test, which is the quantitative like antibody test, and they have these symptoms and they've had the history of Lyme, I think that's a fairly strong argument that there's probably active infection going on. Still doesn't prove it. I actually really, just because it's an indirect antibody test, I've been doing more fish tests for Bartonella and Babesia, because they're pathogens, organisms that can be detected in the blood. And especially in this realm that's so unsettled and complicated in the realm of psychiatric symptoms and these tick-borne illnesses, it's really helpful to have a fish test that, for example, is positive for Bartonella, because then you can really, you have a stronger argument, I think, to say, okay, this patient has classic symptoms that we have seen with Bartonella, with neuro Bartonella, and now we have a positive fish test. This is like an argument that this is really likely contributing.
Yeah, it's a direct test as opposed to
and I guess I use, as an infectious disease doctor, I use syphilis as an example. I see, like, I every week I get asked to review patients with, positive RPRs, syphilis serology is positive, and they've got positive syphilis serology, but they never remember getting a rash. They never remember getting, an ulcer. And then they show up years later and they have an antenatal clinic, or they show up for some reason, they're positive RPR. Well, they've got syphilis. The syphilis is subclinical, and I think the same thing can happen if you don't treat them, then when they become 40 or 50, they can get reactivation of their, syphilis from immune senescence, and they develop Louis, which is, the CNS syphilis. The French called it the English disease. The English called it the French disease. So Louis, named after Louis, the king of France, who went mad from syphilis. Well, he had fun when he was 18. He may have developed a rash. He may have developed, an ulcer, but the virus, the bacteria went dormant. And I think the same thing happens with, with Borrelia, with Bartonella, with some of these other subclinical infections. And when I see patients, you know, I kind of say, oh, do you think you just got recently infected, or do you think maybe you got infected 10 years ago, and then, you know, the second hit hypothesis, the first infection you just controlled and it went subclinical, and then all of a sudden you got a second infection, or you got COVID, and then your immune system went down and these infections reactivated. So I think people can have some of these infections for years and years. I mean, I have a case of a kid that I'm convinced probably got Bartonella, was fine, and then get COVID, and then all hell broke loose. He developed neuropsychiatric problems. He developed skin rashes. He developed pains in his feet, you know, and he responded to Bartonella treatment, having got COVID and then long COVID. But it was, you know, so I think any kind of immune suppressing event, whether it become whether it's a vaccine, whether it's COVID, I think can reactivate underlying dormant infections that the immune system is controlling. So it's you know, it's a brave new world out there. You know, the challenge is we don't have good diagnostics.
And hopefully they're working on them. I think in my practice, I've seen many patients who have been on a journey to figure out what's wrong for 10 to 15 years, which is unfortunate. I also wanted to mention in your talk, Dr. Delaney, you mentioned the peptidoglycan as a possible inflammatory marker. According to some microbiologists, peptidoglycan is only made when the bacteria is growing and splitting. And Lyme has a very specific peptidoglycan. So when I see that, I think of it as active infection. This has been talked about by you, but I'll highlight it a little bit. Dr. Delaney, on your pearls, you mentioned seroconversion as one of the indications of Lyme. We do know that there are seronegative patients. We do know that in some Lyme models, the bacteria appears to hamstring the immune ability to seroconvert. And I think you've answered this, but if you indeed clinically suspect Lyme, or clinically, if this can be said, confirm Lyme in your mind, and you can't get a positive test, can you speak to how you might approach that patient? And that to both, maybe.
Yeah, I mean, surprisingly, and I don't know that I would have guessed this before being in the field, but surprisingly, I actually don't encounter that conflict very often. And I think that's because when I see a new patient, I test them for pretty much everything you can get in a tick. If they're presenting with clinically suspicious illness for tick-borne illness, and I check for everything, I usually find something positive. So I rarely, if ever, run into a situation where you have a seronegative Lyme disease or tick-borne illness case, but they have kind of classic symptoms that are suggestive, especially if you kind of do a comprehensive evaluation and you're using like trustworthy labs. I would say on occasion, I would have a situation where maybe someone presents with 4 positive IgG bands on the Western blot kind of thing, or they have only a positive C6 peptide ELISA, something like that. To me, that's a strong argument. But I rarely have a situation where people have classic symptoms and everything is negative.
And I think to highlight the pearls that Dr. Fallon gave was specific for Lyme. So what you're saying is you expand that, as I think we all should, to tick-borne disease. And you think about, well, if they got an Ixodes bite, what else is in that bug potentially? So I think that's an important thing to highlight here, that we actually are talking TBD, not specifically just Lyme.
Yeah.
Jack, anything to add?
No, and I think in the last few years, I think rather than hanging your hat on Lyme disease and nothing else, I think is really important. It's probably multiple infections. And, when I see patients, I say, your history is suspicious for a tick-borne infection, but there's lots of other bacteria that can, also cause these symptoms, from chlamydia, pneumonia to mycoplasma. So it's multiple tick-borne infections and other non-tick-borne infections that might be contributing to these symptoms. And, my approach is to put people on a trial of antibiotics, because the current diagnostic testing is imperfect, and about 2/3 of people respond to the antibiotic treatment. And until we have 100% accurate PCR tests that diagnose all these infections, it's much better to give people a trial of antibiotics. And people talk about the dangers of antibiotics. This is an antimicrobial stewardship. Well, what about a lifelong, diagnosis of a chronic infection that has no opportunity for recovery? I think it's much better when you suspect a bacterial infection, Lyme or a co-infection, based on your clinical history, based on the clinical manifestations, to give a trial of combination antibiotics covering the likely pathogens. And then if they don't respond, you can always stop the treatment. But if they don't respond and you stop the treatment, then they have then the outcome is suboptimal. With antibiotics, if you suspect an infection, there's an opportunity for cure. And I think that is, that is the reason that I continue to take care of these patients, because I see 70% improvement or cure. And, with people who have been infected for years and years, and put in the psychiatric category, put in the fibromyalgia category, put in MECSF, those are not diagnostics. These are just descriptions of their clinical symptomatology. So I just think we need to continue to, until we have better technology, you really need to think out of the box, not treat the guidelines, and treat the patients.
Well, and I sometimes also will give a trial of antibiotics. And one of the things that Dr. Moziani and others have said, often you see a titer change after you treat. These are stealth pathogens. They do evade immune detection. They are in privileged sites. And I think of it as, once they're dead, they can't evade immune detection anymore. And you see often a serologic change at that point. Yeah. So I think trials of antibiotic in this situation indicates good antibiotic stewardship. I wanted to ask you, Dr. Lambert, if there are any pearls in terms of identifying long COVID. To me, what you said, timing is important. There's something about a magic 3 months. Mm-hmm. But I wonder if there's any other things. You said you can even get long COVID after asymptomatic infection. So that's kind of like the Lyme patient who never saw the tick or had the EM rash. How do you approach that?
Well, think, in Ireland, there's 5 million people. And there's probably 5 million people who have been infected with COVID. He's got COVID once or twice or 3 times. And, if you're sick with COVID and 3 months later, you still have all these clinical manifestations, that are classic for long COVID, it's probably long COVID. If you didn't have a diagnosis of COVID, but you kind of were sick, or, a number of months before, or family members had COVID, and you have all of the clinical manifestations 3 to 6 months later, it's probably long COVID. Unfortunately, there's no magical blood test to prove it. There's no biomarker to prove it. It's common sense seems to be quite uncommon. In our diagnosis, some of the long COVID clinics in Dublin are unfortunately saying, patients who got classic COVID in the hospital, 6 months later, they have joint pain all over, and they have fatigue, and they have tachycardia, they have POTS, they have, brain fog, but, oh, you have fibromyalgia because you hurt all over, you don't have long COVID. I mean, these are, the thing is that it's why do that? You're denying people a diagnosis of long COVID when they had COVID, and 6 months later they have joint pain all over. Well, fibromyalgia is not a diagnosis. I just think we don't have good criteria for, the diagnosis of long COVID. But since so many people were infected with COVID, if you were previously well and 6 to 12 months later you are debilitated with some kind of mystery illness, high probability it was COVID that caused it. I see people all the time that go to the Scottish Highlands, for summer holidays, and then they get a flu, but they never see a tick, they never get a bullseye rash, and then they have all the symptoms of Lyme disease 6 months later, but their antibody test is negative, and they go, you couldn't have Lyme disease. Duh, Lyme is endemic in the Scottish Highlands, all over the place. It's probably number one in my list of possibilities. And what's the harm of giving them a trial of doxycycline, despite the fact they never saw the tick, they never had the bullseye rash, and their antibody test is negative? Because, at least in my experience, 15% of people see the tick, less than 50% of people have the bullseye rash. And studies have shown that the UK Irish, antibody test is at best 53%. So, my opinion is that if I have a suspicion as an infectious disease specialist, I treat. And magically, most of these patients get better, much better than the option of saying, we don't know what you have, live a life of misery.
Is there any symptoms, any clinical presentation, testing, I think we know, that might lead you to say long COVID versus Lyme disease, reactivated Lyme, cardiac symptoms, respiratory symptoms, atypical clotting? Is there anything, and does it matter? I guess it does matter because you'd be treating the bacteria.
It probably doesn't matter, but like I said, based on if you look at the PET scans of people with Lyme, chronic Lyme with long COVID, they have the same kind of abnormalities, hypoperfusion defects in the posterior part of the brain, and that kind of signals all of the symptoms, I think, of long COVID, most of the symptoms of long COVID and chronic Lyme. Now, I saw a patient recently with long COVID who got COVID 6 months later developed a brachiocephalic blood clot. So I think, and she's got all the symptoms. You could say they were chronic Lyme, you could say they were long COVID, but I haven't seen a lot of, kind of blood clotting symptomatologies related to, chronic Lyme. However, I have seen, neuroinflammation of the blood vessels in the setting of Bartonella. So, but the thing is there are things that differentiate long COVID from chronic Lyme, but they're more similar than they are different.
Dr. Delaney?
Yeah, I would agree. I don't typically see a lot of people who would be coming in with a long COVID presentation only. However, I can say I've seen numerous patients who have come to me and their symptom onset was either shortly after getting COVID or having one of the COVID vaccines, and within days or weeks, they have all of the symptoms that actually look like a Lyme disease presentation or tick-borne illness, suspected symptoms. And then you do testing and they're positive for Lyme disease and or like other co-infections as well. So I agree with Dr. Lambert. I think my best guess in those situations is that like the tick-borne illnesses were present for a while and they were probably dormant and the immune system kind of had everything under control. And then there was like this multiple hit hypothesis. immune system is like overstimulated or dysregulated, and then it's kind of out of control, and that's when we see the symptoms. So I have seen that a lot.
I'm wondering if there are ancillary tests. You both in your presentation mentioned Alcott's study on the PET-CT, and you just mentioned it, Dr. Lambert, the neuroinflammation. What about other testing that might support a diagnosis of Lyme or long COVID? Dr. Lambert, you've mentioned lymphocyte subsets. I know I do skin biopsy for small fiber neuropathy. Does the PET-CT have a place? And we've mentioned the orthostatic vitals, and I'm thinking both testing and the exam room. So
every patient I see, when I see them baseline, you know, whether it's Lyme disease or long COVID, I'll do just a basic full blood count, renal, liver, bone, chemistries, CRP, you know, autoantibodies, immunoglobulins, lymphocyte subsets, you know, and then I'll test for Lyme if they're long COVID. I'll test for CMV, Epstein-Barr virus, IgG, IgM to see if there's, you know, new infection or reactivation infection. So I'll do a whole battery of tests. But despite doing all those tests, I would say a third of the tests are abnormal, but 2/3 of the tests are normal. And this is the challenge, is that not everybody has these abnormal tests, but it is helpful to see immunoglobulins that are abnormal, to see autoantibodies that are present, to see lymphocyte subsets that are suppressed. And interestingly, in the setting of, we did a study at the Mater Hospital looking at the acute COVID patients who ended up in the HDU or ICU. It's published, you know, by one of my junior doctors, Brendan O'Kelly, and patients who were admitted to the ICU with COVID, you know, 10% of them had reactivation of you know, herpes simplex, reactivation of zoster, or interestingly, they did some bloods, they did PCRs for Epstein-Barr virus or CMV, and some of those ICU patients with COVID had, you know, PCR positive EBV, PCR positive CMV, which I've never seen except in the setting of AIDS or transplant patients. So they're obviously they're getting, their lymphocytes were low as well. So just like the setting of HIV and AIDS, as your CD4 lymphocytes get lower and lower, you get reactivation of latent bacteria, you get reactivation of latent viruses. And in some patients with long COVID, we're seeing that. Similarly, in some of the patients with chronic Lyme, I saw patients with chronic Lyme just last week, as our CD4 count was like, I think 230, which is close to what you used to diagnose AIDS back in the olden days. A CD4 less than 200 gave you the diagnosis of AIDS if you're HIV positive. So I do think viruses and bacteria cause immune suppression, dysregulation, and this can cause to reactivation of viruses, reactivation of bacteria. But not 100% of patients have these. So we don't have good markers. I use these tests just to kind of support the fact that I'm treating people, you know, and sometimes I use them to monitor whether they change in response to treatment.
And Dr. Delaney, any additions?
Yeah, in terms of your question about PET scans, I think that they could be useful potentially in the future. I think they're very difficult to get insurance approval for them. I think I have one colleague who often does brain PET MRIs, and usually we see like a global hypoperfusion or metabolism. But generally not the most practical. Just regular brain MRIs often can show white matter abnormalities, which obviously in the setting like of a kid or a young adult is not a normal phenomenon. So that can be helpful. I also, similar to Dr. Lambert, I do a lot of, you know, I do a full kind of immune workup, quantitative immunoglobulins. Sometimes we see deficiencies. Sometimes I see elevations, strangely, which I don't know what to make of that. But I frequently also, I would say probably 25% or more of my patients with chronic Lyme disease, including kids, have elevated thyroid antibodies. which is perplexing, I think, and concerning. So yeah, we see a lot of like abnormal immune markers in the setting of Lyme disease.
So I'm going to move on to treatment, which we've touched on. In terms of treating Lyme, can you speak to duration of antimicrobials? How does one figure out MICs in the context of a stealth virus that doesn't seem a stealth pathogen that doesn't seem to develop really resistance, but has tolerance based on its persister state? Any comments to how you kind of make that judgment of length of treatment?
Well, I mean, the thing is that guidelines are guidelines, and the guidelines in Ireland is 2 weeks of doxycycline cures everybody with Lyme disease. But if you look at the literature, including Steer's publications, 2 months of tetracycline didn't necessarily cure Lyme arthritis. So the guidelines seem to have ignored all of the historical studies that have shown that. So my approach to treatment is really, put people on a combination of antibiotics that are, but are both taking care of the blood pathogen, but also the intracellular pathogen. So some antibiotics are better than intracellular, penetration. So rifampicin is usually an important regime. Azithromycin is an important regime. Cefuroxime, amoxicillin, high dose. There is no magic remedy, I don't think, for managing of Lyme and co-infections, because, like I said, we don't have good diagnostics. So you can have Lyme, but you could also have anaplasma. You could have Lyme, you could have mycoplasma, you could Lyme, you could have Bartonella. So I usually treat people with a combination antibiotics plus LDN and supplements to work on the immune system and work on inflammation at the same time. Duration of treatment based on symptoms, that's really it. So I don't believe that you should be treating people for years and years of antibiotics, but sometimes you don't know whether a person's going to respond to the antibiotics after 2 months, but usually after 3 to 4 months, two rounds of antibiotics, if they don't respond, I don't usually persist with treatment with antibiotics. At that stage, I usually say, well, let's really focus on the immune system. Let's focus on inflammation. Let's focus on viruses. But we don't really have good guidelines at the present time for management of Lyme co-infections. We had a recent case of somebody with Bartonella who actually went to brain biopsy because they thought they had a brain tumor. And on biopsy at the neurosurgical center in Dublin, it was PCR positive for Bartonella, but the peripheral, the blood antibody test was negative for Bartonella. Since you can't biopsy everybody's brain, you have to kind of, get back to the point of you need to actually, treat people based on your suspicion. And then how long do you treat? I mean, there's data from Moss and Yemi for Bartonella that the PCRs are still positive, but decreasing, after 6 months of treatment. So, so 1 month of antibiotic treatment, according to, IDSA guidelines, doesn't treat everyone, So the challenge with Lyme is that we have guidelines for treatment of acute Lyme. We don't have treatment for chronic Lyme because there's still not a recognition that chronic Lyme exists. We using Q fever as an example. If you catch, Q fever is very common in agricultural countries. It's very common in Spain. And my colleagues who manage Q fever in Spain, if you catch it early, 4 weeks of doxycycline does the job. But if you miss the diagnosis in 4 weeks and you don't diagnose them to 12 months, it takes, the guidelines say 18 months of doxycycline and hydroxychloroquine. So, this is the challenge. We have no guidelines for the management of many of these chronic tick-borne infections. There's not even a recognition that they exist. So until that happens, I treat patients based on my suspicion, and I treat them for as long as I think they're improving on treatment.
I often similarly think in 3 to 4 months, I tell my patients we're doing a treatment trial. If in 3 to 4 months, you don't know we're on the right track and I don't know we're on the right track, we have to reevaluate. So I have a similar time. Dr. Delaney?
Yeah, I mean, I think I would echo what both of you say in terms of, I wish that there was like I mean, it is very frustrating to be in this field without any treatment guidelines and sort of being a physician who's treating an area that's just a completely new frontier in so many ways. I typically have a fairly, I think, conservative, prudent approach, and try to taper antibiotics, like assuming that things are helping within a few months, I would probably try to taper or stop antibiotics. But if symptoms come back in that setting and they're tolerating the antibiotics okay, then I think that's like a solid argument or rationale for continuing with treatment. One of the interesting things that Dr. Lambert said about Q fever, that there are some of these obscure infections that the infectious disease community don't really recognize as tick-borne, like Q fever or brucella. And interestingly, there are like guidelines for those infections. And so that's part of the reason that I check for them, because I actually see a fair number of people coming up positive for brucella, for example, even though it's not really acknowledged as a tick-borne illness. I see it a lot in this population. And the nice thing is that there's like clear guidelines about how to treat brucella, unlike sort of swimming in the ocean of chronic Lyme disease where there's no guidelines and there's so much controversy.
Yeah, and I would just say that, I think as clinicians, you're putting yourself at risk because it continues to be a real huge political hot potato. Poland, for example, there's now legislation to prevent doctors from treating Lyme disease for longer than 1 month. And actually, penalties of the equivalent of $120,000 if they treat for more than 1 month. So a lot of the private clinics in Poland, I mean, Poland has, the as huge epidemic of tick-borne infections, Lyme disease. 70% of the woodcutters in eastern Poland are positive for Lyme antibody, and 30% of them are sick. So, and my colleagues in Poland say there's, in a population of 11, 13 million, there's probably 1.1 million people infected with Lyme disease, and many of those chronically, and they're now being legislated. You can't treat for more than 1 month, or you will be punished with $120,000, penalty. It continues to be a huge, and I'm seeing patients now referred to me in Ireland because they can't get the treatment in Poland anymore. So it really is kind of it's not an infectious disease, it's a political disease. And, I use the analogy, if you were in the ICU and you had a patient with sepsis, and the guidelines say treat sepsis for 10 days, and they were still hypotensive and had a rash after 10 days, you'd say, oh, the guidelines say stop after 10 days. You wouldn't do it. But with Lyme disease, common sense, patients get better with treatment. When you stop treatment, they get worse. Oh, the antibiotics must be working. Let's give a longer course of antibiotics. No, you can't do that. You will be penalized by having your license taken away and getting $120,000, punishment for it. It's beyond science. It's really a political hot potato that those of us who do it have to accept.
Is there a place for antivirals in long COVID?
Yeah, well, absolutely. I think, I saw some recent I used to selectively treat for patients who are, some of my patients with long COVID got repeated herpes outbreaks. 33-year-olds getting 3 outbreaks of shingles in 1 year. I just put them on Valtrex 1,000 milligrams, because Valtrex 1,000 milligrams works for herpes simplex, works for herpes zoster, probably has some activity against HHV6, HHV8, probably doesn't hit CMV, probably doesn't hit Epstein-Barr virus, but I think it made sense to do that just to keep the virus suppressed. I saw some recent publications that actually clinicians were seeing benefit of treating people with Valtrex, or they used acyclovir to suppress the potential reactivation of herpes viruses. And also there was kind of a suggestion that antivirals also suppressed IL-12, one of the cytokines, one of the bad cytokines that might be contributing to inflammation. So yes, I do think there probably a role in using antivirals. The trouble is, it's basically a trial because we don't have any good markers, there's no blood test to really prove that they have viral reactivation.
I want to touch base on controlling inflammation before we wrap, because that was one of the things that both of you mentioned as important in terms of the disease. Early on in Lyme, patients often got a steroid treatment before the Lyme was recognized. And it was noted that those patients had a harder time recovering from the Lyme and required longer treatment. And there's a paper from Dr. Paul Ewald, who's an evolutionary biologist, entitled An Evolutionary Perspective on Infectious Causation and Antibiotic Treatment. And in that paper, he's talking about chlamydia pneumoniae, but he mentions that sometimes what we're calling post-infectious illnesses have been proven to be continued chronic infection. And again, the case of chlamydia pneumonia, but both in the heart and in spondyloarthropathies. And he argues that if you use immune modulators, such as a TNF alpha suppressant, that you might actually support the continued infection by chlamydia. So both of you have mentioned anti-inflammatory. Shannon, you mentioned IVIG. So I'm curious about how you see that in terms of immune suppression and immune support and anti-inflammation. And then I want to talk about LDN too.
Sure.
So Dr. Delaney.
Okay. So yeah, it does get a little bit complicated. I see a lot of these pandas kids who have a history of infections, either strep or Lyme disease or mycoplasma that's triggering their psychiatric symptoms and presumably causing the brain inflammation. So we do see that IVIG can be helpful in that setting. There's so much individual variation. Like there can be one kid who sort of presents clinically the same as the next kid, and the first kid responds beautifully and dramatically to IVIG, and the second kid doesn't respond at all, or their symptoms worsen from IVIG. So I think that there is concern with IVIG that if you have active infection at the time that you're getting IVIG, that at the very least you should make sure that you have antimicrobials on board, oftentimes combination treatment, because I have seen neuropsychiatric symptoms worsen in that setting of IVIG. So it's not like it's a cure-all and that people like miraculously get better the second IVIG is started. That being said, the most complex patients that I've seen, like complicated neurological, complicated psychiatric symptoms from tick-borne illness, usually get better with a combination of oral plus or minus IV antibiotics and IVIG, but it doesn't always.
Right. So I think going back to the very early days of HIV and AIDS, I mean, I'm an old guy, so I used to see patients. I was in Rochester, New York, training in 1981. And, I saw AIDS patients in 1985, and we had no treatments for HIV and AIDS. And we used IVIG. We used LDN back in those days because there were no antivirals. Yeah, and patients progressively got lymphocyte depletion, immune dysregulation, people with HIV and AIDS did. And they piloted LDN, and LDN had anti-inflammatory effects. LDN had immune modulating effects, and its placebo-controlled trials showed it seemed to improve, patients temporarily with HIV and AIDS, which is a virus that damages the lymphocytes, causes immune dysregulation, causes autoantibodies, causes pain, causes brain inflammation, and then, like I said, complications, neuroinflammation, thrombocytopenia, IVIG was given for that. So, so I think we've had experience in other, viral diseases when there were no good treatments for the use of IVIG, for the use of LDN. So I used to treat people with chronic Lyme with just antibiotics, and then I realized that when I stopped the antibiotics, they improved on the antibiotics, and they get worse when they stop the antibiotics. And I use the analogy of HIV, is we used to treat people with HIV before the days of antivirals, HIV antivirals, for all the infections they caught, and they got better when we treated them with the antibiotics. When they stopped the antibiotics, these infections came back again, and it wasn't until we actually had anti-HIV antivirals that replenished the lymphocytes, the CD4 lymphocytes. They were at zero. A normal lymphocyte count is 500 to 1500, CD4 lymphocyte. CD4 lymphocyte help fight infection, clear infection, and actually lymphocytes orchestrate your immune system. They probably control mast cells, they probably control allergic reactions, et cetera. So back in those days, I used to treat people for infections, and they got better. And when I stopped the antibiotics, a few months later, the same infections came back again. So treating Lyme disease, I realized chronic Lyme, they were immunosuppressed as well. So you need to do more than just treat the infection. You needed to repair the immune system, and you need to work on the inflammation. So I started using LDN because it works on the inflammation, it works on the immune system. There's placebo-controlled trials in HIV and AIDS that show benefit. There's placebo trials in neurologists have done studies on atypical MS that it works. Rheumatologists have done studies that that LDN works. It has some kind of anti-inflammatory immune modulating effects. And we did a pilot then, like I presented on long COVID patients that I saw at the Mater Hospital, back in 2000, the first year into the COVID pandemic, because I was seeing these patients who were just not recovering, and LDN seemed to help those patients. There's been a recent study from the Veterans Administration's hospital looking a retrospective review of, long COVID patients, looking at 4 different treatments that they used in the VA hospitals, and LDN came on top for being the most beneficial in terms of helping long COVID patients. So we still don't totally understand, what LDN was, but it has some kind of anti-inflammatory immune modulating effects. And it's a very safe drug to take, However, despite all of that, in Ireland, none of the long COVIDs will prescribe LDN because they say we practice evidence-based medicine, and evidence-based medicine says we don't give people any treatment. They just keep on doing one test after another, spending thousands and thousands doing tests on cardiology tests, brain tests, biopsies on the nerves, et cetera, but no interventions. And people go for years after years seeing a neurologist, or endocrinologist, a rheumatologist, every specialist in the world, cardiologist, but at the end of the day, no treatments. And I don't think LDN is a panacea. It's not the total solution, but it's part of the solution because it works on inflammation, it works on immune regulation, which is part of the problem in chronic Lyme, which is part of the problem in long COVID.
And the risks sound very minimal. I want to touch 2 more things before ending. One is the vagal brainstem dysregulation. What we see in this elevated sympathetic tone and this suppressed parasympathetic tone. You both mentioned things that should be done for that. Shannon, you mentioned meditation, certain supports. I know there's research from Dr. Porges about how to rehab the vagus nerve. Dr. Lambert, it was clear from your who do you need to know about this stuff. You need a village. You need everybody to know about this stuff. I find in my world of private practice, it's nearly impossible to get any of these things supported by insurance. It's nearly impossible to get antibiotics. So I'm wondering, in your practice, how do you approach rehabbing outside of removing the cause as best we can? How do you rehab that system?
Okay, so I'm an infectious disease doctor, but in January of 2021, all the publications I was reviewing basically said, you know, the complications of long COVID are not the heart and the lungs. The problems are the brain. And what you need is you need to have neurorehabilitation. It's the brain inflammation that's triggering all the symptoms. And I took courses on, you know, brain trauma and neurorehabilitation. And I think, you know, and even today, you know, most of the long COVID clinics are run by pulmonary specialists and by cardiologists and by infectious disease doctors who don't have a clue about the brain. So the issue with long COVID is neuroinflammation, and the sympathetic parasympathetic system. There are training, there are breathing exercises, there's exercises to retrain the sympathetic parasympathetic system. That's important. You know, for the vagus nerve, there's exercises to retrain the vagus nerve. There's transcutaneous vagal nerve stimulators that are being used, you know, that have been used for psychiatric problems. I think actually Brian Fallon's been involved in some studies using vagal nerve stimulators. I mean, you know, this is not my specialty. I'm an infectious disease doctor, but I've tried to learn more about neuroinflammation because I think that's the problem. So I think we need to really focus on, you know, using neuropsychiatric specialists, using neurorehabilitation specialists. You get a car accident, you get a concussion, you get brain trauma. You know, they have a lot of the same symptomatology of our chronic Lyme patients, of our long COVID patients. So I think we need a multidisciplinary team. We need to kind of use the tools that are available for, you know, brain trauma, to apply them to long COVID, to apply them to chronic Lyme co-infections.
Dr. Delaney, anything to add? Because that is more or less your field.
Yeah, I mean, I just would say that I agree. Most of these patients that I see with Lyme disease have an overactive sympathetic nervous system. And so anything to kind of slow that down, whether it's just like some of the basics of making sure that digestion is happening properly, they're sleeping okay. And, you know, I often will recommend sauna, breathing exercises, meditation, yoga, all of those things to increase parasympathetics. I also am excited about Dr. Fallon's study. Hopefully he can find something interesting. There's also vagus nerve stimulators that you can buy commercially too. There's other wearable devices, such as like the Apollo Neuro, that help to like increase your heart rate variability and presumably decrease stress. So I think there's a lot of interesting things on the horizon that might be ways to intervene.
The one other thing that was mentioned is altered neurocircuitry. Dr. Delaney, you mentioned that that was one of the etiologies that has been proposed. And I've had experience with a few of my patients who went and got transcranial stimulation, which is magnetic, which is approved, I believe, for depression by the FDA, but not for cognition. But there is evidence that it helps cognition. And two of my Lyme patients went from being completely disabled to back to work after a session of this. I have the opinion that you have to reduce the inflammation before trying to reestablish neural networks. Because I think what's disrupting the neural networks is that inflammation. So I wonder if you have any experience with that or have seen any of that. I know it is approved for depression, so.
Yeah, I would say I too only have probably a handful of patients who have done TMS in the setting of chronic Lyme disease, and I have seen some improvement, but I've seen others who haven't really had improvement. Possibly it was because they have active inflammation, like you mentioned. You know, there's a lot of different things that can alter neurocircuitry, like psychiatric medications can, going out, exercising regularly can. So yeah, I think I also use low-dose naltrexone a lot. So there's a lot of different interventions that can work in that domain.
I'm just checking that we've answered all questions from the audience. And I think we have. This was to Dr. Lambert. We've talked about low dose naltrexone. Any evidence, I believe this is another webinar, but I will ask the question. Any evidence of benefit from vitamins and other supplements as some patients are being treated by alternative medicine practitioners?
Right. Okay. So, I actually do, I use a series of supplements as well in taking care of my patients, for long COVID. I mean, I always say, when I see patients, I say, sleep is important, having neuroinflammation. So melatonin, if you have sleep disturbances, occasionally you do need to use, to repair the serotonin circuit as well. So there is a role for kind of low dose, medicines that kind of, focus on that as well, although I'm not an expert in that area. They've done studies in looking at speeding up recovery from COVID by addressing the microbiome, so probiotics, kefir, those kind of things. Most of your immune cells are in your gut, not in your blood. So, so there is evidence that manipulating the microbiome can help as well. And then for the mitochondria, there's the use of products like NAC, N-acetylcysteine, glutathione, so we all kind of have our protocols, and I tend to put people on a multivitamin that includes coenzyme Q10. I do agree that using a multifaceted approach to the treatment of these conditions is important, because it's neuroinflammation, immune dysregulation, mitochondrial crashing, virus reactivation, microclots. These are all of the pathogenesis that have been described as contributing to long COVID. No studies, however, have been done looking at therapeutics to reverse that process. So pilots of LDN, I think it's promising, but we need to do an efficacy trial, pilots of, probiotics for the guts for long COVID, studies of using anti-COVID antivirals for long COVID. I've not seen any studies that prove that worked. There is this theory that there's persistent, COVID 6 months down the way that's contributing to long COVID. I don't think that's I think that happens in occasions, but I don't think that's predominant trigger for long COVID. We've got a long way to go. But I think it's probably important to use a combination of safe products until we have the magic bullet and the magic cure for long COVID. And that's the approach that I take.
And thank you, Dr. Lambert. Thank you, Dr. Delaney, for your time and your expertise and your clarity. Your presentations were crystal clear, which was wonderful for me.